Good afternoon. We're excited for you to join this webinar. Western Maryland Health System and entrepreneur students from University of Maryland Smith School of Business have teamed up to deliver this important discussion on redesigning healthcare delivery through value-based care. Proceeds will benefit Western Maryland Health System Foundation. And shortly, Barry Ronan, President and CEO of Western Maryland Health System, will offer his thoughts on the topic and provide insights into making the transition to value-based care for your hospitals. Barry will present for an hour and then immediately following lead into a Q&A session. If at any point you have a question during the webinar, please feel free to submit the question in the Q&A tab on the right-hand side of your screen. We hope you find this webinar both informative and interesting. And now let me introduce Barry Ronan.
Good afternoon. As Lauren said, I'm Barry Ronan, President and CEO of the Western Maryland Health System. And thank you for joining us today. This is something that we have not done before. We usually have done this in our boardroom with lots of different folks being around the table and then doing tours and what have you. So this is somewhat of a new venture for us. Joining me today is Nancy Adams. Nancy is our Chief Operating Officer as well as our Chief Nurse Executive. And as I had mentioned a few seconds ago, we in fact have done this probably for about 20 hospitals and health systems across Maryland over the last year. It actually has proven to be very beneficial for the attendees as well as us learning some things from them. We want to make sure that we have time to answer your questions, so we'll leave certainly, hopefully, enough time at the end. In the event that we run over, or you don't get the opportunity to ask your question, please, we will have our contact information at the end, and you can just email us, and we'll certainly share whatever information we have. And certainly if you hear of something that we talk about and you want to actually have a copy of that, we can certainly make those arrangements as well. Before we actually get into the presentation, maybe a little bit of background here. We are one of 9 hospitals that participated in this demonstration project, and you'll hear a little bit more about this over the last 4 years. It actually has proven to be very beneficial for our health system as well as the 10 or the other 9. And then since January of 2014, we in fact have seen all of the Maryland hospitals are now under a similar value-based care delivery model. As part of our value-based care delivery journey, just a quick story. In September of 2013, I was contacted by a reporter of the New York Times who was actually referred to us by Maryland's Secretary of Health at the time. During a previous visit by the Secretary of Health, he was very impressed with the changes that he saw related to our care delivery model, and based on that visit had suggested that we in fact that this reporter speak to us. The article appeared in the New York Times in late August 2013, and it covered the success of total patient revenue or value-based care delivery in Maryland. Since then, a number of us have spoken across the country and preparing hospitals who in fact are about to embark on these changes for their respective organizations. A pretty poignant quote from the article: this hard scrapple of a city at the base of the Appalachians makes for an unlikely hotbed of healthcare innovation. Yet Western Maryland Health System, the major hospital serving the poor and isolated region, is carrying out an experiment that could leave a more profound imprint on healthcare than President Obama's reforms. And that was, again, Eduardo Porter, who was the New York Times reporter. I have to say, quite honestly, since 2013, we have done a lot more as it relates to improving our healthcare delivery model, which you'll hear about in a little while. We received a great deal of recognition over the last 2 years. As I'd mentioned, we in fact have been speaking all over the country. We've had close to 20 hospitals come to the Western Maryland Health System to learn about value-based care delivery. A little bit of who we are. We built a new hospital 5 years ago, a 270-bed hospital, Western Maryland. We consolidated 2 campuses on a greenfield site to build the new hospital. We are located in one of the poorest counties in one of the nation's richest states. We have a skilled nursing facility as part of our health system. That's an 88-bed facility. We are the region's largest employer with about 1,850 employees, 250 physicians on staff, 90 advanced practice professionals. We are one of 9 trauma centers in the state of Maryland, and we have an open heart surgery program. And just within the last year, we're part of a newly formed alliance between 3 hospital system group called the Trivergent Health Alliance. So it's the Western Maryland Health System in Allegheny County, Meritus Health in Washington County, and Frederick Memorial Health System in Frederick County. A little bit about our operating revenues are $330 million, give or take. 11,805 adult admissions per year. That's actually down from 15,521 when we started this process. So that's about a 24% decline, and that expectation will continue, that we will be continuing to decrease our admissions. 53,000 emergency department visits per year. That's down about 3,000 since 2011, and we stand pretty much pat at about 1,000 deliveries per year. We have over $300 million in economic impact for the region as the largest employer, and our community benefit for the last 4 years has been close to $160 million. For those of you that may not be familiar as to where Cumberland is, it's again located in Allegheny County. We have Pennsylvania to the north of us and West Virginia to the immediate south. We serve 2 counties in Maryland, 2 counties in Pennsylvania, and 5 counties in West Virginia. A little bit more about our journey now. In 2011, we were approached by the Health Services Cost Review Commission in Maryland. That's the group that sets rates for hospitals for the state. And they asked if we would be interested in joining 9 other sole community providers on a demonstration project called Total Patient Revenue. After the discussions with our board, we agreed, and just a little bit about what Total Patient Revenue is. It's a shift from volume-based care to certainly value-based care. 100% of our revenue is fixed. There's no change based on fluctuations in volume or changes in service. We received incentive monies up front to assist with the transition from volume to value, which is pretty significant, and I'll cover that in a few minutes. Providing care in the most appropriate location, and you'll see how we've transitioned our care delivery model. Our previous competitors are now our partners with aligned objectives that we actually had to go out and make sure that they understood what the changes were and what their role would be. And as I mentioned earlier, as of January of 2014, all hospitals in Maryland are under a bundled payment methodology. The next 2 slides pretty much tell the story on the transition to value-based care delivery. In the traditional fee-for-service care delivery model, you can see the acuity on the left axis. And certainly everything pretty much revolves around the acute care hospital, the emergency department, with community care or pre-acute and recovery and rehabilitation care, post-acute being secondary. If you then look at the next slide, under our model, we certainly are focusing on ensuring that we're delivering the most appropriate care in the most appropriate location, whether it's a specialty clinic, a physician's office, a medical home, or a skilled nursing facility. You can also see that the home is anchored on either end, so there's much more care that's now being delivered in the home. And our previous competitors, in many cases, are now our partners. When we were first asked to consider the demonstration project, we engaged KPMG. They were somewhat familiar with the whole concept of value-based care delivery and what would be expected under total patient revenue. They assessed our organization. We all felt that this was certainly right for the organization, and we actually used them to present this concept to our board because there was a lot to make sure that our board understood those changes. So some of the initial reasons were we were seeing an aging and declining population in some of our communities. We knew that volume would be in fact changing, decreasing. We expected reductions in payment. The economic incentives offered by the HSCRC, and this was unique to the 10 TPR hospitals, whereby they gave us monies up front to assist us in transitioning from volume-based care to value-based care. So for example, in our first year, we added 15 new care coordinators to our health system, and that would have certainly had a burden on us if we would in fact had to add them without any incentive dollars. We saw it as an opportunity to jump on the learning curve related to the triple aim of healthcare reform, and certainly what was happening with the Affordable Care Act and where the future of healthcare delivery was headed. In those board presentations, some of the keys to success were covered, shifting our emphasis again from volume to value, a focus on reducing admissions and readmissions, as I mentioned, providing care in the most appropriate location. We've created a much stronger patient engagement process through this new model. We've reduced variation in the care delivery as well as the quality. We've improved payment alignment with our physicians, and you'll hear a little bit more about that as we go on with this presentation. And we have the opportunity to reinvest the savings that we are generating through this process. So any money that we in fact are saving through total patient revenue or value-based care delivery, we get to keep and reinvest in our health system as it relates to adding resources to assist us with this delivery care model change. We are also allowed to invest in the community with partners who are assisting us in keeping folks healthy and out of the hospital. A lot went into getting our community partners to understand the change in our care delivery model. I have to say there was clearly a trust issue as to what the intentions of the health system may have been through this process, because we've had a history of competition. With many throughout the community being replaced with partnerships to care for patients in the most appropriate location. So we had a challenge there. We also, and this continues today, focused on reduced utilization. We're looking at reduced admissions, readmissions, emergency department visits, overall ancillary utilization, and again, that will continue well into the future. The first 2 years were extremely challenging, getting our staff as well as our physicians to understand how we're going to be doing business going forward. So I use this quote, reorganizing the delivery system is unbelievably resource intensive and fraught with unintended consequences. I used it extensively with my board because this was a pretty significant transition and clearly a departure from where we in fact had been previously. We actually ended up holding mandatory education sessions for all of our employees, endless meetings with our physicians, and we're constantly reinforcing the differences between volume and value. Many people ask, how did you get your physicians on board with this concept? Because it is a dramatic departure from volume-based care delivery or fee-for-service methodologies. In order to get the physicians on board, we in fact established what was called the President's Clinical Quality Council. It was formed with 12 physicians. We actually started with 6 that members of the C-suite agreed upon and selected. These were the official leaders, the unofficial leaders of the medical staff, the early adopters, the movers and the shakers, and we asked them if they would in fact identify 6 additional members that we could add to form this 12-member council. They did. We formed the council, so the council would meet on a monthly basis as a regular meeting, and then outside of those meetings, they would in fact do work, and they were paid $250 an hour for every hour that they were engaged in this process, and that actually helped us greatly. We improved the coordination of care both internally as well as externally. We enhanced the quality of care being provided overall. We created a pay-for-performance initiative with our physicians to better align those incentives. We used data to improve care. We focused on issues such as denials, length of stay, PPCs, potentially preventable conditions, readmissions, as well as use rates, and we addressed unnecessary inpatient care. And actually what has evolved is we've created a clinically integrated network at the Western Maryland Health System, and this council has evolved to serve as the leadership for that network. Some of the challenges that we had when we first started under value-based care delivery, it was interesting. We engaged the consultative services of the Berkeley Research Group to determine the high utilizers with multiple comorbidities. So for example, in 2010, it was identified that 1,972 patients accounted for $140 million of our annual cost. I mean, we were shocked at that number. It's important to note that as of fiscal year 14, that number has dropped to 1,300 at $81 million. So we clearly have made a great deal of progress in that particular area. We had to maintain market share while reducing admissions, which is part of the whole TPR concept. We had to expand primary care access. So what we did was we did a zip code analysis. We went into those areas where we were seeing many patients coming in, utilizing our emergency department. And in many cases, certainly, those visits weren't necessarily warranted. They were more level 1, level 2, or in some cases, people utilizing it more for longitudinal care. So through the zip code analysis, we were determining where those pockets of patients were coming from, and we put primary care, additional primary care practices in those areas. As I mentioned, we focus on unnecessary utilization and appropriateness of the admissions. We educated both the internal as well as the external stakeholders on the changes in care delivery. It's actually been very helpful, and we have created what's called Meeting the Challenge of Healthcare Change. So anything related to volume-based care delivery has been put under that in educating our community. Now for some of the initiatives and strategies that we've put in place, starting more from a pre-acute perspective. We added a number of primary care practices, as I just mentioned, and continue to bolster them today. We've created the Center for Clinical Resources, a medical home or a specialty center to care for those patients with chronic illnesses, such as diabetes, congestive heart failure, COPD, and other respiratory-related diseases, asthma, hypertension, and anticoagulation. There is no charge to use this center. Excuse me, and you'll see in a moment as to the significance of that. As I mentioned, we formed a clinically integrated network with our physicians, as well as established an accountable care organization within the last year and a half. We're keeping patients, excuse me, keeping independent physicians engaged with visits to offices and meeting with staff and practice administrators. We have a number of physicians who no longer practice, have a hospital practice, only an office practice. So it's critical to make sure that they remain a part of this process. Moving to acute care, obviously a lot of focus on those high utilizers or the sickest of the sick. We're focused on the appropriateness of admissions versus the number of admissions. We review daily every readmission within 30 days to determine the reason for that readmission. We treat it very much like a root cause analysis to get better understanding of why that patient had to come back in within those 30 days. We've formed teams of clinicians to round daily on patients with a length of stay or 3 days or longer. And our nurses round hourly on every patient and perform shift report at the patient's bedside. So we have actually a greater chance of involving not only the patient, but the family. We actually share data in the form of a scorecard with our individual physicians based on their performance. So we have a team of physicians and nurses who work with those physicians that are particularly non-compliant related to readmissions, use rates, denials, length of stay, and PPCs. And a lot of this work actually came out of the President's Clinical Quality Council. So for example, when we started the President's Clinical Quality Council, we use them as our group to bounce ideas and thoughts off. So before we actually released our scorecard to our physicians, we had them go through it, make sure that it made sense. We revamped it repeatedly, and it actually ended up being a very good process for us, and one that was accepted by their colleagues in the organization. We revamped all of our patient education programs. We have assigned pharmacy staff to the emergency department as well as the inpatient rounds, and that has been invaluable. In fact, our nurse managers have said if you take our pharmacists off of the units, there will be a revolt. They do so much as it relates to medication reconciliation, as well as rounding and educating patients and their families on any medications or medication changes. We've created a dedicated group of care coordinators as well as a clinical coordinator within behavioral health. And the significance here is we've determined that about 50% of our acute care patients also have a behavioral health diagnosis. Accurate clinical documentation as well as coding has been absolutely key to this process. A great deal of emphasis has been placed on the education of our physicians as well as our advanced practice professionals, and the concept of hot topics also grew out of our President's Clinical Quality Council, where we have educational sessions on a quarterly basis for physicians as well as advanced practice professionals, focusing on those areas where we have our greatest need. And clinical documentation was clearly one of them, and there are many examples to go along with that. We changed our discharge planning process to make sure that we were covering patients all the way until they saw their next primary care provider. We would actually make appointments with them or for them in the event that they did not have a primary care physician. Again, discharging patients with their medication, which has been a very valuable program going forward. Moving to post-acute, we, as I had mentioned, follow up on all of our discharge patients. So we actually, once they leave the hospital, we're continually following up with them with our CareLink coordinators. We've expanded our home care resources. In fact, within the first year, it grew over 35%. We created teams of community health workers, which actually go into the home. They actually do not provide care, but what they do is make sure that the patients have their appointments, they're taking their medications, they have their medications, they're checking their weight, their blood pressure, etc. We've created a skilled nursing facility transition care coordinator, so we have nurses that are going into our skilled nursing facilities throughout the region who in fact are following the patient from discharge to the point where they go into the nursing home as a resident. They pretty much do report for the skilled nursing facility nurses. They reconcile medications. That has been exceedingly valuable. And then they follow that resident for the through the next 15 to 20 days. We also have created SNFs, so they're skilled nursing facility hospitalists, if you will. So it's physicians and nurse practitioners, nurse practitioners within our own skilled nursing facility as well as within others, and they have replaced the medical director for that skilled nursing facility, and they're providing care on a real-time basis. So no more picking up the phone, calling the medical director, or the medical director says send them to the emergency department. Now we have a team that actually responds and assesses that patient in the nursing home. We are seeing much more care that's being actually delivered in the nursing home than ever before. We've established our partnership to perfection with area skilled nursing facilities, and that was to get them to understand the change to value-based care delivery and rebuild that trust. Again, as I mentioned, we have our own skilled nursing facility. We need to make sure that they understand that we're all partners in this, that we use our skilled nursing facility for more of the hard-to-place patients. And then we connect it with our patients to make sure that they're getting the services that they need after discharge. Under our potentially preventable conditions, which is the Maryland Quality Measure, you'll see on here that we perform urinalysis on every patient admitted through the emergency department to identify a present on admission UTI. And the focus there is under potentially preventable conditions. There's a $14,500 penalty for every UTI that is not identified on admission. We determined that a urinalysis is about $1.53, so it's amazing as to the improvement that we were actually able to do through that very simple process. We've expanded our care coordination in our emergency department as well as throughout the health system to a 24/7, 365 days per year. As I mentioned, we have our Center for Clinical Resources, which deals with our very high-risk patients, and we actually visit them prior to discharge to get them engaged with the center. We've created a multidisciplinary readmissions committee that has been instrumental in making sure that we are focusing on ensuring as to how we in fact can prevent readmissions. And we actually have much greater accountability on our staff, focusing on quality as well as reducing cost at the health system. We've had a favorable impact on the health of the community as well. We've decreased hospital stays. We've reduced the number of uninsured by actually, we have our own counselors who will register folks in the health exchange in Maryland. We have improved diabetes monitoring as well as reduced emergency department visits. We've We've reduced the tobacco use with pregnant women, reduced the rate of behavioral health admissions through better access to mental health services in our community, as well as additional social support. We've improved infant mortality within our community. We've experienced an improvement in cancer mortality rates, and we've reduced the rate of emergency department visits for our asthmatics as well as our folks seeking dental care. The bottom line, we have found that we have significantly elevated the delivery of care over the last 4 years. I mean, it's absolutely amazing as to the changes that we've seen throughout the organization with our staff as well as our physicians and certainly our patients. Now for some of the results. Our inpatient admissions, as I mentioned at the opening, we reduced our inpatient admissions over the last 4 years by 24%. Inpatient readmissions over the last 3 years have declined 33%. Our skilled nursing readmissions are down 38%. Our inpatient behavioral health admissions are down 8%. The readmissions are down 9%. We, in fact, have reduced our emergency department use rates by 3%, ED admissions by 6%. The use of our observation unit is down 10%, and our hemodialysis admissions are down 32%. So you can understand the pretty dramatic results that we're seeing through this process. The impact of the Center for Clinical Resources has been dramatic. We, in fact, have declined. Our admissions for diabetic patients have declined 27%. We've seen a 16% decline in our emergency department visits for our diabetic patients. Congestive heart failure patients, a 36% decline in admissions, and anticoagulation is 70% reduction in readmissions. And all of this adds up to a cost savings and avoidance of close to $5 million in our first year. And the significance there is that that savings is what allows us to not charge our patients. So because we're generating such a significant savings, and that's what our focus is under total patient revenue or value-based care delivery, it has been a great benefit to the health system. So again, we don't charge any patient for any service related to the Center for Clinical Resources. An important addition to our to the oversight of our value-based care delivery model was the creation of the Triple Aim Coordinating Council. And the significance here is that we were finding that we would be putting initiatives in place throughout the health system. And you can see on the right-hand side of the slide some of the areas that we, in fact, were focusing on. And, you know, we'd have these in effect for 6 months, and then we'd go back to check on them and realize that somebody stopped it after a period of time because, quite honestly, they didn't understand why we had it in place. So I created the Triple Aim Coordinating Council. I serve as the chair of this group. And quite honestly, we provide the oversight for all of the initiatives that we've put in place over the last several years, as well as if someone would like to make a change to one of those initiatives, it has to come before this council. And you can see the membership. We have physicians, RNs, executives, as well as folks from wellness, quality, informatics, IT, general operations, as well as care coordination. And then any initiative that someone would like to put in place based on something that they may have learned or read about or heard, and that has to come before this group as well. So quite honestly, it has been an exceedingly invaluable addition to this whole process to make sure that what is being put in place remains in place and that it continues to be viable. We've already begun to expand care coordination into our clinics as well as our physician practices. We're always looking at how do we create more value through this process. We're moving into home monitoring technology, and that is being linked through our home care as well as care coordination efforts. We're expanding telehealth initiatives by providing tablets to high-risk patients and directly linking those back to providers. And we're moving forward with a dedicated palliative care program. It used to be linked with our hospice program, but now we feel that it requires a dedicated program. From a community health needs perspective, a lot is being done with our community partners related to the community health needs, but we still have our work cut out for us. Some of the latest data shows continued areas of focus with access to healthy foods, affordable housing, children living in poverty, as well as among violent crime. A high incidence of colorectal as well as lung cancer and heart disease, all related to poor nutrition, lack of physical activity, tobacco use, as well as drug use. So a lot is going on with our partners in the community. And as I mentioned earlier, we have the opportunity to take some of the savings that we're generating and reinvesting it into the community and working with these partners. So for example, we're providing funds to the food bank, our County United Way, Associated Charities assisting us with medication. The Human Resource Development Corporation is assisting us with transportation needs, and the list goes on. So we've developed these relationships and partnerships throughout the community to assist us with certainly addressing community health needs. Some of the programs to address these needs that I just covered, we have cancer prevention forums going on throughout our community. We have a Smart Move, so it's a youth wellness program for youth and their families. Family fun and fit challenges, and a lot of this is being done through the Board of Education, our local YMCA, and other organizations. We were embarking on our first community garden, so we have a 600 square foot plot that we in fact are opening to the community. It opens actually today, and where we're in fact have developed partnerships with local businesses. So for example, Lowe's is providing assistance. One of our lumber companies is assisting us. The City of Cumberland is providing water to the site. The University of Maryland is in fact engaged in this process as well, assisting us with more of the agricultural aspects of it. So when you say it takes a village, we in fact have developed numerous partners to assist us in this process. And as I said, this is our first one, and we hope it's one of many. And then what we're also looking to do is eventually be able to bring fresh fruits and vegetables into parts of our community that may not have that ability to either afford or obtain fresh fruits and vegetables. We may end up actually having supermarkets dedicated to these types of products in some of these more distressed areas. We do grocery store tours in every major grocery store throughout the area, and that has been exceedingly beneficial and certainly well received and well attended. And then a lot is going on led by the health system related to the development as well as the promotion of bike and pedestrian routes for riding as well as walking. We're also taking a leadership role in addressing poverty in our community, and I look at this and it seems like a daunting task, but we recognize clearly that it's a marathon and not a sprint. We have involved the business community, the faith-based community, County United Way, the YMCA, the Board of Education, city and county government, all in this initiative. And our goal, quite honestly, is to move individuals from poverty to self-sufficiency. We're looking to reduce the social costs related to crime, poor health and welfare, and certainly strengthen the educational attainment, as well as the job skills. At the end of the day, this all assists greatly with economic development, revitalization of neighborhoods, and just makes people feel better about themselves. So as I say, it appears to be a daunting task, but it's one that we feel we have an obligation based on some of our new responsibilities related to being a safety net for the community. It's also important through this process to, on an ongoing basis, to identify the challenges that we in fact have been experiencing. Our use rates at the health system still continue to be too high. We have to be constantly looking at that balance between length of stay, readmissions, as well as discharges. We have a continued focus on those potentially preventable conditions as well as hospital-acquired conditions, because there's so much based, for example, in Maryland on quality-based reimbursement as relates to risk as well as reward. So we're constantly focusing in those particular areas. We have misaligned incentives with our physicians. We actually have a pay-for-performance program. We have gain-sharing initiatives that have evolved with some of our contractual physicians. And we're also seeing incentives through our clinically integrated network, but we're constantly focused on those misaligned incentives and what can we do to bring improvement there. Many social issues exist among our residents as well as our patients, and as I mentioned earlier, we've played a much greater role as the safety net for the region, something I never imagined we would be doing 5 years ago. It's changed that dramatically. And as I had mentioned earlier, as it relates to community health, there are improvements have occurred in overall health of our population, but certainly work still needs to be done there. And again, the areas of focus: housing, transportation, food availability, as well as poverty and crime. So I am often asked, could I ever go back to a fee-for-service or volume-based care delivery model? The answer is an emphatic no. I have seen the dramatic differences in the lives that we've made in individuals through improved care delivery. And we are constantly focusing on individual patient health and certainly keeping folks out of the hospital. When I mentioned earlier about 1,972 patients accounting for $140 million of our cost, and you've seen by focusing on those the sickest of the sick, those high utilizers, and case managing many of them individually, we've been able to get that number down to about 1,300 individuals accounting for $81 million of our cost. So that's a pretty dramatic decrease. But as I said, some of the stories that we're hearing from particularly the Center for Clinical Resources and the improvements that they're able to make in some of these chronic patients with chronic conditions, it's been absolutely unbelievable. So all in all, it's been an exceedingly valuable process, a valuable journey, and we're just pleased that we've been a part of it. So actually that worked a lot faster. I hope I didn't speak too rapidly throughout this process. I have a tendency to do that from time to time. So what was in preparation was about a little under an hour. We've actually been able to keep it to about 45 minutes. So if you could submit your questions, as well as, and you'll see actually, as I mentioned at the beginning, some of the contact information that it's actually on the next slide. So in the event that you don't have the opportunity to get a question in, or if in fact you want more information, please email us or get in touch with us, and we'll share whatever we have with you. With that, questions?
Actually, we had some questions that came in a little earlier while you were talking. The Center for Clinical Resources seems like a very interesting concept. Can you explain a little bit about how that works and how well it's been received by your medical staff?
Nancy, you want to talk for a little while?
Oh, sure. I'm happy to give you a break. That was a lot of information in a little bit of time. I will be honest and tell you that there was a lot of anxiety associated with opening this Center for Clinical Resources. Many of the physicians felt we were taking some of their patients. We explained the concept in a lot of detail as just another door into their office. We did it in groups. We did it one-on-one. We made sure that we connected with all of the critical members of the medical staff. Of course, as you know, with these things, a little bit of doubt was still in force until we got up and running. I will tell you that if we tried to close the Center for Clinical Resources, the medical staff would really be up in arms. To put it succinctly, the Center for Clinical Resources does many of the things that consume a lot of physician time. And so we really have been a good adjunct practice for them, and they're very happy.
You also demonstrated that you've seen a decrease in your admissions and your ED visits. What has been the impact on your staff?
Right. I'll take that one as well. I think one of the most valuable initiatives that we brought forth was we required education for all of our existing staff, and that goes on every month as we orient new hires to the health system so that people really understand not only what we're doing, but why we're doing it, and they can really buy into the whole concept. Once they understood that, they became very adept at finding out how they could function in areas that they were not used to functioning in. For instance, if we have fewer inpatient admissions, one can conclude we would have a need for fewer professional nurses. The nurses stepped right up, attained the skill set they needed to move with the patients, if you will. So as we saw more patients in home health and increased that staff, we were able to easily fill the open positions, and I believe a very positive outcome in that we've not lost any positions in the health system based on the changes in our approach to care.
How did you prepare your board of directors for moving in this new direction?
I'll take that one. We're very fortunate. We have a very progressive board. I think this is a board that a number of years ago, we formed the Western Maryland Health System. There were 3 freestanding independent hospitals in Allegheny County. One of them was acquired, and that became our nursing home, but then the Catholic and the secular hospital came together to form the health system. So a lot went into that, and the board clearly seized on the importance of making that happen. We then embarked on building a new hospital, so there was a lot related to that whole process. So the board had a lot of trust in us, if you will, making sure that all of these things came on board, and certainly they all had their challenges, but we were able to certainly make it happen. So when it came time for talking to them about total patient revenue, they actually listened. As I mentioned, we brought in KPMG, who had a good understanding of where this was all heading, and made the presentation to the board. And we had a number of meetings associated with it for them to get an understanding what the differences were going to be between volume-based care delivery and value-based care delivery. We answered their questions, and then they agreed that we in fact should proceed. And I will tell you, they are absolutely thrilled. And we go to governance-related meetings all over the country, and you bring board members, and folks are now just starting to learn about value-based care delivery, and the board members are sitting there and say, don't you take us to more progressive educational sessions? And I keep saying, well, they're going to catch up at some point, but they are exceedingly pleased and exceedingly proud of what we've been able to accomplish here.
You showed the slide earlier, the continuum of care and all the different providers along it. How receptive have they been to working with you? For example, the skilled nursing facilities?
The skilled nursing facilities, we are somewhat at an advantage in that we are not dealing with 100 facilities. We have about 15 that serve our community, and we started talking to them in the beginning, and there was quite a bit of, I guess, trepidation on their part in terms of what's the health system doing now. I'm happy to say that we started our program, Partnership to Perfection, made them understand that we are very dependent on them to accomplish what we want to accomplish in delivering care in this community. We have meetings every other month, and the attendance is extremely robust. For the cost of a lunch to the health system, we get so much information and a very vibrant exchange. To this point, now that we've been meeting 15 months, I would say the trust level is extremely high. We've put a lot of programs into place in each of the skilled nursing facilities that we use the same kind of forms for discharge, for admission, those kinds of things that are all patient focused. And so we now all believe we're working toward the same goals.
Actually, if I could add to that, I think a great example is as we were embarking on value-based care delivery, a new urgent care independent provider was moving into the community, and we actually reached out to them and said, we'd like to partner with you. And they said, wait a second, we don't hospitals don't partner with freestanding independent urgent care centers. We compete. And once we explained to them what our model was as it relates to value-based care delivery, that our goal was to keep folks healthy and out of the hospital, caring for patients in the most appropriate location, that they would be most beneficial in helping us to deal with the level 1s and level 2s that would normally come to the emergency department. But if we could get them into urgent care centers, I mean, we have 2 of our own urgent care centers within the health system, and there are others in the community, and this is just one more that would assist us in this process. So, and we've had a very good working relationship since their arrival. So again, that's the change. I mean, previous competitors are now working in partnership with us.
Another group that would be affected by a decrease in volume would be, for instance, the physicians in the emergency department. Have they been cooperative working with you during this process?
They have been cooperative because we work with a group that we've developed a very high level of professional relationship. And as we move into these new initiatives, they are always willing to help us and working towards, for instance, the SNFIS program that Barry mentioned. We use that same company, different group of doctors. Every concept we come up with last week, Barry read something about advanced practice nurses actually being on ambulances for patients that may or may not need emergency services, and seeing patients in their comfort zone, in their own home location. So we have a meeting next week again with these our providers in the emergency department to see how we can make that happen.
And how did the transition from volume-based care to value-based care really affect your approach to strategic planning?
It actually, it was amazing as to the change that took place as it relates to the new value-based care delivery approach. We pretty much had to, we had a strategic plan that was in place when we had made the decision to then proceed under total patient revenue or value-based care delivery. And we pretty much had to put that on the shelf and revamp the whole approach, because it was a dramatic departure from the focus of growing inpatient services and adding additional services in the community, especially within our health system. We had built a brand new hospital through this 5 years ago, and through this process, which we did not anticipate when we were designing and opening the new hospital, that this change was in fact coming. So it was, we now actually have an architectural firm that we're working with to constantly look to repurpose this new facility, because we built 275 beds. Average daily census now is about 160 patients, aside from certainly the flu season. But on any given day, as I say, it's about 160. So it's a pretty significant change that we've had to deal with. So all of those initiatives have been incorporated into our strategic plan, the work that we're doing with our health department, the community partners, that's all part of it. It's just, as I say, a pretty dramatic shift in strategic planning through this value-based care delivery.
Outside of the state of Maryland, I know Maryland has a lot of incentives for value-based care. Are you starting to see other states or other health systems outside of Maryland embracing value-based care?
I can answer that. We actually, as I mentioned, we had probably close to 20 hospital or health systems come and visit. The great majority of them have been in Maryland, but we in fact have had individuals who have come. We've also done conference calls with folks wanting to know more about the change. I'm constantly going to meetings and engaging folks about their care delivery model and talking about what it is that we're doing. I've had the opportunity to speak across the country to numerous groups. I had the privilege of being invited to speak to the American Hospital Association Board of Trustees at one of their strategic planning retreats to talk about our experience. And they said, you know, this is the direction that all hospitals will be going. It's just a little bit slower as to it coming to fruition, but it's going to happen. And as I said, we have numerous hospitals that continue to reach out to us, and we're certainly, you know, it's a journey that we've been through, and you know, I like to say that we're the footprints in the virgin snow. No others have been through this outside of Maryland to the extent that we have, so we're very willing to share the knowledge base that we've gleaned through this process.
What are some of the ways that you're working to address the social needs of patients? Is it done on an individual basis with the care coordinators, or how does that work?
We do a lot of that through our widespread care coordination approach. And I will say that each of those needs is fairly individual. It could be, Barry mentioned earlier that our population, about 50% of them have a mental or behavioral health component. So those social issues, where they live, where they eat, we had a contingent of patients that come to the emergency department just because they're hungry. So those are opportunities to partner with other members in our community. I'm not sure if we mentioned or not, but we had an opportunity last fiscal year to contribute pretty substantially to places like County United Way, the food bank, those agencies that support the social needs of the patients in the community. In terms of the Center for Clinical Resources, I did want to add one point. We talked about the services are free and the savings are now close to $5 million. It would be very important to understand the impact, though, the Center for Community Resources has had on patients with chronic conditions such as congestive heart failure, diabetes, COPD. Those patients had a very miserable quality of life. Since they have regular care, they have goals that are set and achieved. It's a much happier, much more stable population. And as a health system, that's something we can really be proud of.
You know, we have an advantage, certainly, being a sole community provider in a more rural area. And because some of the examples, as I had mentioned earlier, any patient that has a length of stay of 3 days or greater, we do rounds on those patients and have physicians and nurses and nurse practitioners all engaged in that process, as well as teams of other folks. And we were finding that there were reasons as to why these folks, very simple reasons as to why these folks were remaining in the hospital and not being discharged. I mean, we had an individual who was here for 8 days because they needed a shower chair. So we're talking about thousands of dollars incurred in costs related to that patient remaining in the hospital day after day after day, and they needed a $35 shower chair. So we have empowered our employees to a much greater extent to deal with those kinds of issues. That if in fact that need exists for an individual patient, exercise the authority that you have been given to make changes in order for that patient to be safely discharged. We've had individuals who in fact couldn't get back into their homes or couldn't get out of their homes because they needed ramps built. We reached out to a variety of folks, and again, this community partnership, within a day we had a ramp built to a patient's home, so she in fact didn't have to call the ambulance in order to go out and make physician appointments. I mean, so it's been a very dramatic change, and we're dealing with folks on a more global basis, but we're also dealing with issues that they may have individually.
In Western Maryland, it sounds like you have just the single Western Maryland health system, and you own already a lot of the services that you need in the continuum of care. How would this discussion differ if you were in an area where you had people who were not associated with the health system or had multiple hospitals?
From the perspective of Maryland, I mean, it's now all Maryland hospitals are delivering care under a value-based care delivery model, and the learning curve is pretty steep for the other hospitals that just started under this in January of 2014. They're still trying to learn this process, and it's very challenging to get people to understand. I will tell you, we went out and spoke to every community group that we possibly could. As we've mentioned, we went out and formed this partnership for perfection with all of our skilled nursing facilities throughout the region to get them to understand the changes. We're meeting with physicians that may not have been directly connected with the health system to get them to understand. It takes a lot of work to get people to understand the changes and how care is going to be delivered going forward. And that fell to us. I mean, that responsibility fell to us, and also getting the community to understand. And we are working, as I mentioned earlier, that we formed this Trivergent Health Alliance we have 3 hospitals. We competed to some extent, but not extensively. But we actually all got together and said, this is probably something that we need to do. So we're focused on population health, clinical quality, as well as sharing services. And we're projecting actually in the by year 3 that we will have saved over $25 million across the 3 health systems. So, I mean, there's a lot that can be done, but it takes time, and it also takes a lot of dialogue.
Right.
As I say, it's a challenge, but it can be done.
It comes down to the crucial conversation, taking the time to meet one-on-one with people that previously you may not have had that kind of relationship with, and the hospital understanding we are not the end all. We need every partner in our community to work with us, and we've had great success with those conversations.
What are the greatest challenges in engaging patients and their families now that they need to be such an integral part of their care?
Well, I guess I'm going to take that one.
Chief Nurse Executive,
Yeah.
You should.
I think that where we started, at least as our baseline, is in the last 2 years, it's patient and family-centered care. And so we've begun, as Barry mentioned, with the bedside shift report. We try to do that at a time when the family's present. We want the family involved and committed to the plan of care for every patient that we care for, whether that's inside our building or any of our entities outside of the main hospital. So the family involvement in the next year will evolve more into the application of technology such as tablets, telemedicine, telehealth, a lot of onus on the patient and the family caregiver to be involved in the patient's success. To that end, we are looking at how do we provide education for a diverse group of caregivers that are going to be faced with challenges they haven't encountered before once that patient goes home with a whole new set of limitations, plans, medications. It's very complex. So we believe it's going to be a little challenging, but certainly not daunting. We'll be able to do it.
Well, as Nancy mentioned, telehealth. I mean, how many times you have a relative in the hospital, you wait hours for a particular, for the physician to come around, and you miss them because you've gone off the floor or something. We're looking at mechanisms to provide for e-visits and e-rounding as it relates to having the ability for the physician and that team of nurses that are doing those bedside rounds interact with the family remotely.
So far, it's been pretty effective. I think in most hospitals across the country would have the same experience. The family members do want to be involved. And when they don't, it becomes our responsibility then to find the support and resources necessary for each individual patient to have the best outcome they can possibly have.
So are there any more questions out there?
Well, this has really been an enjoyable experience and another opportunity to talk about the good things we're doing here. As Barry said earlier, my contact information is available. If you just email or call, we will be happy to provide. We're extremely transparent. We'll share any of the tools we've developed, any of the concepts. We're very happy to let you have them.
Actually, we have one more question.
That's good.
All right, we've talked about a lot of different groups. What about the general public? Have they noticed a change, or did you do anything to let them know about the changes that you've made?
Well, as I said, we recognize that the general public were going to be absolutely critical to this process because it's they would hear all of these negative aspects of Obamacare, and say what you want to say about the insurance side of Obamacare, but I will tell you from the triple aim perspective of reducing cost, improving quality, and improving overall community health, we have seen that has had a dramatic impact on our community. Is it absolutely perfect? Everyone falling in line? That's not the case. But as I said, we have seen significant improvement in this community. So that has been exceedingly advantageous. It's been an exceptional process. It really is.
All right, Mr. Ronan, Mrs. Adams, at the end of our questions. Would you like to
actually, in closing, I would just reiterate what I said earlier, as well as what Nancy said. We've been through a lot over the last 4+ years with this process. If you have questions or need information, as I had mentioned, we in fact did mandatory education for all of our employees. We've shared some of that information with folks who have come and visited us. We've done tours of our Center for Clinical Resources for folks who have been in Maryland. So if you're in fact close by and that's something that you would like to do, just certainly let us know. So our email information is available, or if you want to talk to us in person, that can be arranged as well. I thank you so much for taking time out of your day to support certainly the University of Maryland's entrepreneurial studies class, as well as to support our foundation through this process. I hope you found it to be beneficial. Thanks.
Thank you.